All right, so we're going to start off with diagnostic challenges in cutaneous soft tissue tumors. I do both dermatopathology and soft tissue pathology at the Cleveland Clinic, so it's nice for me to be able to combine the two. Okay, all right. We'll do a little case report. And this is an old case, so I'll apologize for some of the qualities of the photos in this case, but it's a great case and it sets up an illustration for some other more recent material that you probably should be aware of. This is a 67-year-old woman with a hand mass, and the clinical diagnosis was pyogenic granuloma. And I have to admit, this is a very early case I had in my practice. And this is what we had. So we have this polypoid lesion on the hand, and you can see it's got this sort of sheet-like proliferation of small round blue cell tumors, blue cells. And I'm thinking, okay, and you see these, ectatic vessels. I'm a pretty young dermatopathologist. I think I can figure this case out, right? So, pretty uniform, monotonous cells. There is a mitotic figure in the center, but they're pretty uniform and monotonous. There's not a lot of pleomorphism. So it's on the hand, acral surface. So I know, I'll do some immunostains, and that will really solve the problem, right? Because immunostains solve everything. All right. So I thought, well, maybe it's a Merkel cell carcinoma because it's an older woman. So I did CK20 and synaptophysin. They're negative. Okay, all right. So it's not that. That's no problem. Okay, I know. Maybe it's some kind of adnexal tumor. Well, A1, A3 is negative. So now I'm starting to get a little nervous. And is it melanocytic? No, S100 is negative. Okay, I know now what it is. Not melanocytic. It must be a glomus tumor. SMA, completely negative. In desperation, I did an LCA, okay, and that's negative. So now I'm really sweating. Now I don't know what the heck this thing is. All right, so now what? Well, go back to first principles. It's a uniform small round blue cell tumor. And so I did a CD99, and you can see this has got diffuse, crisp membranous staining throughout the lesion. And back in the day, we did Fly1 stains. We don't tend to do those anymore for diagnosing Ewing sarcoma, but this is diffusely positive, and this is indeed a cutaneous Ewing sarcoma. So it does happen in the skin, which you have, it can arise primarily in the dermis or the subcutis without bone or skeletal muscle involvement, and you have to make sure it's not a metastasis. These are rare. Now, usually you see them in children and adolescents. You don't usually see them in elderly patients, but, the tumors don't read the books. And when they present in the skin, they tend to present as relatively small nodules.
All right, meningiomas and mesenchymal tumors. Okay, so I showed this earlier today. So actually, the single most common primary CNS tumor is meningioma, which accounts for about 40% of all the intracranial tumors that we see. So it's extremely common. And if you look at benign tumors, it accounts for over half of all the benign tumors that we see. It's common enough that it makes the news every few years. Usually a female celebrity will bring this more into the limelight. So Elizabeth Taylor had a meningioma, Mary Tyler Moore had a meningioma, almost always a female celebrity because the female to male ratio is about 2-to-1. And in the spinal cord, it's as high as 10-to-1. So we don't know entirely why that is. We think that it's at least partly due to hormonal influences, but no one has completely explained why that is. It's also an age-associated tumor, so the older we get, the higher the frequency. So here's meningiomas. GBM is down here. Where is GBM? It's one of these. I think it's the red, or all of the other gliomas. So you see when we get older, meningiomas way outpace the gliomas. So of course, most of these are benign, so it's not the problem that we face with the diffuse gliomas, but the older we get, the more common these are. We think these come from arachnoid cap cells, though it's never been absolutely proven. but that's the kind of dark green layer that you see here, and you see it's right under the dura, which is probably why these are so often dural-based tumors. And it used to be thought many years ago that trauma was one of the causes of meningiomas, but that has never been proven. And the only two things we know are causes of meningiomas. One is hereditary syndromes, especially NF2, and the other one is prior irradiation. And meningioma is one of the most common radiation-induced tumors that we see. But still, like almost every other tumor we deal with, the largest proportion is idiopathic. We don't know what caused it, or it may just be bad luck, maybe a random mutation. So the classic cases...
So we'll jump right in from brain tumors to molecular updates in GYN Path. So tomorrow, I promise you we're going to do the nitty-gritty stuff that on next Monday you'll be able to use, like intraoperative GYN, hard endometrial biopsies. Today we got to take a little bit of a step back and look at the molecular classification of some stuff that's happening in GYN. And the main reason is because pretty soon this is going to affect all of us. But I will talk about that in a second. Today, we're really going to focus on endometrial carcinoma. One, because it's super common, and two, because that's where the major big splash is recently. There is one other molecular thing you should be aware of that I'm not going to cover today simply because we don't have time. Uterine sarcomas, not leiomyosarcoma, but if you're thinking stromal sarcoma, undifferentiated sarcoma, those now really should be classified molecularly. So send it out to an institution that can do that. The really big ones, big reference labs will do that. Okay, so all of you have seen the breast cancer one towards the molecular classification of breast cancer. Now we have our heat map. This one is of breast cancer, but we also have a similar heat map now of endometrial cancer. And here is the publication came out a bit ago looking at genomic characterization of endometrial carcinoma, which is starting to going to affect us if it's not already affecting you. So why do you actually need to care about this at all? Well, the FIGO staging just changed. I don't know if you guys are aware. And right now, molecular classification is encouraged, but is still optional. But that is going to change. And I can tell you that the GYN oncs are pretty soon going to want all of this if they aren't already. So as pathologists, we are already doing this at our institution, and our GYN oncs definitely are using it to treat their patients. So let's take a step back and look at this. Endometrial tumors, they're going to cluster into 4 groups. This was as of 2013 and still stands. So you're going to have your POL-E mutants, your MSI hypermutated ones, we'll talk about all of this, your copy number low and your copy number high groups. And there were several studies, you may hear GYN oncs and tumor boards always talking about PORTEC this and PORTEC that. And basically, all of these studies were looking at how can we separate different endometrial cancers to determine how to treat who gets aggressive.